Good afternoon, dear ladies and gentlemen. Let me thank organizing committee and especially Professor Kwan Kun Lee for the opportunity to speak at such a representative forum. The topic of my presentation is dedicated difficult and important problem of treating the patient with Budd-Chiari syndrome. So, Budd-Chiari syndrome is defined as the obstruction of the hepatic venous outflow from the level of small hepatic venous up to the entrance the IVC into the right atrium. Dr. George Budd first described this syndrome in 1845, and Dr. Hans Chiari had clinical and pathological correlations in 1899. And is the first liver transplantation for Budd-Chiari syndrome was performed in 1976 by Thomas Stars. Globally, Budd-Chiari syndrome is an uncommon liver disease, from 1 to 3% of all liver diseases. Budd-Chiari syndrome incident in higher in women in Western country and in men in Asia. In Western country, Budd-Chiari syndrome is characterized by a low frequency occurrence and the main etiological factor such as hematological prothrombotic disorders. In Eastern countries, for example, in China, Budd-Chiari syndrome is characterized by segmental and membranous obstruction of the IVC. There is a primary and secondary Budd-Chiari syndrome. The cause of the primary syndrome is thrombotic or thrombophlebitic occlusions of hepatic vein or IVC. The cause of the secondary is invasion or compression by extravascular lesions. There are fulminant, approximately 5% of all cases, acute, approximately 20% of all patients, subacute and chronic form of Budd-Chiari syndrome. Classical triad, ascites, hepatomegaly, and abdominal pain are the most common clinical features. There are the following three types of acute and chronic Budd-Chiari syndrome. Type A, acute hepatic vein thrombosis or stent block. Type B, non-thrombotic acute insult. And type C, acute hepatic vein thrombosis in a non-vascular chronic liver disease. There are three types of Budd-Chiari syndrome based on the level of obstruction. Type 1, obstruction of IVC with or without secondary hepatic vein occlusion. Second, obstruction of major hepatic veins. And third, obstruction of the small venules. To select treatments, tactics, and determine the prognosis for course of Budd-Chiari syndrome, several prognostic scales have been proposed. The most widely used score including Clichy, New Clichy, Rotterdam score, TIP score, and Mhofto. However, it is important to note that no one of these scores are absolutely correct or accurate. For example, the Rotterdam score takes into account the most common symptoms and level of prothrombotic time. It suggests raising the question of liver transplantation when having class 3 and a probably 5-year survival low than 40%. Hepatic venous outflow tract obstruction takes into consideration the response to therapy and the extent of liver damage. When the degree is greater than 4, it indicates a poor prognosis for the patient and the need for treatment, potentially including liver transplantation. At the same moment, there is an agreement that the treatment of Budd-Chiari syndrome should be staged, complex, taking into consideration its cause, clinical type, and the condition of patient. There is a common trend towards staging transition from anticoagulant therapy to interventional endovascular procedure and liver transplantation. Anticoagulant therapy begins with low molecular weight heparin for at least 5-7 days and long-term use of warfarin aiming for an NRI between 2 to 3. The results of recent Austrian multicentral study showed that direct oral anticoagulant seems to be effective and safe for the long-term anticoagulant therapy in patients with Budd-Chiari syndrome. The next step in the treatment of Budd-Chiari syndrome is the use of endovascular intervention. These technologies have shown their efficiency in patients with acute liver failure and acute and chronic liver failure. For instance, a study involving 553 patients in the Asia-Pacific region showed that the implementation of endovascular procedure in acute liver failure patient resulted in favorable 4-year survival rate. The type of endovascular intervention depends on the extent of the lesions in the IVC and hepatic veins. For example, for type 1, angioplastic or stent can be used. And if you see type 1C, IVC angioplasty and TIPS are recommended. A systematic review and meta-analysis were conducted to examine the effectiveness of TIPS procedure in patients with Budd-Chiari syndrome. The review included 17 studies and found that patient survival was good. Specifically, the 5-year survival rate was 92%, the 10-year survival rate 77%, and the percentage of patients who required liver transplantation after TIPS procedure was very low, only 6%. The first liver transplantation for Budd-Chiari syndrome was performed by Thomas Starls in 1976. In his description of the operation, they highlighted the technical challenges in performing a liver transplant, which included combination of massive liver, cavidot lobe enlargement, retroperitoneal diffuse fibrosis, and increased bleeding. The first living donor liver transplantation performed in pediatric patients with Budd-Chiari syndrome was attempted by Nezakatka in 1999. At the same year, Haberal performed a heterotopic auxiliary left lobe living donor liver transplantation in 70-year-old female with Budd-Chiari syndrome. However, the main challenge in living donor liver transplantation for Budd-Chiari syndrome is the need to reconstruct the retrohepatic IVC. That's why the rate of living donor liver transplantation for Budd-Chiari syndrome in Europe is not higher than 10–15%. According to Japanese liver transplant registry, only 44 living donor liver transplantation in Budd-Chiari syndrome were performed between 1989 and 2014. And to date, only 50 cases of retrohepatic IVC reconstruction in living donor liver transplantation have been reported. A European study in which we participated revealed that the outcomes of liver transplantation in Europe for Budd-Chiari syndrome have significantly improved over the last 20 years. The 1-year survival rate has increased from 71% to 84%, and the 10 survival rate from 61 to 68. Post-transplant oral anticoagulant use was the only additional factor independently associated with improved results. To summarize, the treatment for Budd-Chiari syndrome typically begins with the use of anticoagulants. If they are ineffective, endovascular intervention should be used. In cases of severe liver failure, where other treatments have failed, liver transplantation should be considered. The transplantation program in my country, in the Republic of Belarus, operated based on the national legislation in the field of medicine and transplantation. The legislation is based on the presumption of consent and allow free of charge organ transplant surgeries for all citizens of our country. According to the preliminary data, the International Registry in Organ Donation and Transplantation, our country ranks 8th actual deceased donor, and it's 6th in Europe, actual deceased donor per 1 million population, according to last year results. At the same time, the number of deceased donors is 26 times higher than the number of living donors in my country, which I think is a significant problem for us. Since 2008, we performed 1,100 liver transplants in our center. 89% were performed on adults and 11% on children. The number of liver transplantation from deceased donor in Belarus is 14 times higher than the number of transplants from related donor. And that's why only 65 or 6% of all transplantation is performed in our center from related donors. From 2008 to 2024, 134 patients with Budd-Chiari syndrome have been treated in Minsk Transplant Center. Fulminant form was in 8 cases, or 6%. Acute in 30 patients, or 22%. Subacute and chronic in 96 patients, 71%. IVC obstruction with or without secondary hepatic vein occlusion was in 5 cases, 4%. Obstruction of major hepatic veins in 113 cases, 84%, and vein occlusion disease in 16 cases, 12%. All patients received anticoagulant therapy, low molecular weight heparin, warfarin, direct oral anticoagulant. Endovascular intervention were performed in 38 cases. 6 patients with angioplasty with coated stenting or IVC with without hepatic vein, and 32 patients TIPS procedure. Indication for the TIPS procedure were clinical significant portal hypertension with no response to conservative treatment and combination Budd-Chiari syndrome with portal vein thrombosis. Liver transplantation was performed in 70 recipients with acute and chronic liver failure with Budd-Chiari syndrome, which was only 1.5% of all liver transplants in our center. Or 12% of patients with Budd-Chiari syndrome observed. There were young patients with high MELD score and Rotterdam score who predominantly had hematological prothrombotic disorders. TIPS was performed before liver transplantation in 30% of cases. All liver transplantation was performed with IVC replacement from deceased donors. Venous complications were diagnosed in 22% of cases and were successfully corrected by endovascular treatment. The rate of relopertomy was also high, 23%. Half of all patients had hemiperitoneum. Lifetime oral anticoagulant therapy was prescription for all patients. Hospital mortality rate was 0, with a 5-year survival rate 94 and 10 survival rate 88%. My conclusion, Budd-Chiari syndrome is a rare, complex disease that requires timely diagnosis and early initiation of therapy. Endovascular intervention lead to improved survival in both compensated and acute liver failure and acute and chronic liver failure patients with Budd-Chiari syndrome. Liver decompensation in the form of acute liver failure or acute and chronic liver failure, most common in European countries, in Budd-Chiari syndrome requires liver transplantation for the best long-term survival. Treatment of Budd-Chiari syndrome should be carried out using a stepwise approach that includes the rational use of anticoagulant therapy, endovascular angioplasty, stenting, tip staging, and finally, liver transplantation in the center with experience in the application of all of these methods. Thank you for your attention.